Today on Patients at Risk, 25 patients are harmed and one patient dies after a nurse is permitted to perform a highly specialized endoscopic procedure called an ERCP. Today I'm talking with gastroenterologist Dr. Kaveh Hoda about the slippery slope when scope of practice is expanded to people without the proper training and experience.
My name is Dr. Kaveh Hoda. I'm a GI doctor, gastroenterologist, and I'm also the host of a podcast called The House of Pod. It's a humor adjacent medical program. We'll talk about things happening in news, pop culture stuff. We'll make fun of wellness grifters and medical grifters and that sort of thing. It's a pretty fun show you can find anywhere.
I will definitely link to that podcast because it sounds like some humor relief that we all need these days.
For me, at least, it helps me.
Tell our audience, for those who don't know, what does it take to become a gastroenterologist?
First, I thought you were gonna be like, "What is wrong with you? What would be wrong with your brain that you would want to do this?" It's a question that you get a lot. It's really funny. It's like when a patient rolls in for a procedure, just look at you and they'll just be like, "Why did you choose this job?" Basically, they're saying, "What is wrong with you that you would do this for a living?" But to answer your question in particular, you do have to go obviously to medical school, and then you do an internal medicine training. So for me, that was 3 years. On top of that, you have to do at least 3 years of gastroenterology training. Now, I did those 3 years. I also did an extra year on top of that for liver transplantation. Now, there are some programs that will give you an extra year or 2 to specialize in doing advanced endoscopic procedures, and some places will require that. Long story short, medical school for sure, residency, and then at least 3 years of GI specialty training.
So 4 plus 3 plus another 4?
You could just do 3, but depending on if you wanna spend a little more time doing liver stuff or advanced training, you can. So that's an extra
So at
year.
least 10 or 11 years after college. We're not even
Yeah.
counting that here. And then not all gastroenterologists perform these advanced endoscopic procedures like ERCPs, which is really the thrust of what we're going to be getting into today. What I'm trying to set up here for our audience is to understand that just to become a gastroenterologist at the very, like, I guess, entry level to do the fundamental job of the average GI doctor, you got to go to school for a really long time. And then if you want to do these additional types of procedures in the world of gastroenterology, you got to do even more training. So tell us about an ERCP. What is it and how long does it take to get good at doing them?
Yeah, it is the most difficult, think it's safe to say the most difficult, and it's clearly the highest risk procedure that we do in the world of gastroenterology. So ERCP stands for endoscopic retrograde cholangiopancreatography. So it's a mouthful, sort of a Dr. Seuss word, and I had to practice it a lot just to be able to say it that quickly and that well. Not easy. And it is a challenging and very rewarding procedure. The basic premise of it, for listeners who haven't seen it or done it in medical school or in their training, is you take a long, thin, flexible tube, an endoscopy, and it has a special camera and a light on the end of it. It goes into the patient's mouth, into the esophagus, through the stomach, into the first portion, and then into the duodenum. And from there, we basically try to break in to the biliary duct system. And once we are able to get into those series of tubes that connect your gallbladder, your pancreas, your liver, and your small intestine, we can do things like remove stones, we can put in stents, we can sometimes do cholangioscopy where we actually look with a special camera within the camera to look into the ducts. There's a lot of options from there. But that's the basic breakdown of what we do. And as I think you're going to be getting at, it's a challenging procedure. It's evolved quite a bit over the last 50 years it's been done. And it isn't done by every gastroenterologist. It's done only by a relatively small number of us who do this training. And I do this one thing, this ERCP, with some regularity where I am now.
What's the main reason that a person might have an ERCP done for them?
I think the most common reason in the United States is gallstone related. So if you have gallstones, sometimes those stones will slip into places they're not supposed to be, like the bile duct system. That can cause pancreatitis. That can be very severe. There's also cholangiocarcinomas, cancers, pancreatic cancers, things that are causing a blockage of the bile ducts. There are less common things from there, but those are probably the two most common things that we will be doing procedures for.
It's a tough procedure to do, and I guess the stakes are pretty high, which is why you have to train so long. What are some of the things that can go wrong if you start messing around with this procedure, but you don't really have the skills to do it?
Well, I mean, the procedure, it can be bad even if you do have the skills to do it. I have to preface this by saying I don't know any advanced endoscopist who has not run into, at some point, complications or problems. It is something that can happen even in the best hands. Anytime you do a procedure, obviously, there's always a risk of bleeding, allergies, problem with sedation. Perforation is a big one for any sort of advanced procedure or invasive procedure like colonoscopy, endoscopy. But in this world, the thing that is probably the specialized issue that we always have to be mindful of and talk to patients about is post ERCP pancreatitis. It's funny because sometimes we go in to help someone with gallstone pancreatitis, but we can also cause pancreatitis. And that can happen anywhere from about 3% to, in high risk patients, 15% of patients. So it is a significant risk. And the mortality associated with it is significant. It's about 3%. First of all, anytime you have pancreatitis, it's a serious thing. It's terrible for a patient and it hurts, obviously, in the best case scenario. Most patients, thankfully, will improve with just IV fluids, being MPO, and rest. But sometimes it's worse. So it can be very significant. The other thing to keep in mind is that there is always a risk of post-sphincterotomy bleed. So when we go in, as I said, we try to break into this bile duct system, we have to make a small incision or a cut called a sphincterotomy there of the ampulla, the sphincter, and that can bleed. And that is not insignificant. That can happen in about 6% of cases, some degree of bleeding, and maybe even up to 8%.
So it's a pretty high risk procedure from what you're saying. It sounds like you really need to be skilled. So I'm very glad that you're here with us because I want to describe a case that we've read about recently. It was published in the BBC News over in England. And the scenario is a 73-year-old woman who developed abdominal pain. We don't know a whole lot about the case. And of course, you were not involved at all in this case. So this is just speculation. But it was determined that she needed to have an ERCP done. I'm guessing they thought maybe she had stones in the bile duct. So she had an ERCP done, and instead of being by a gastroenterologist and certainly not an advanced endoscopist like you, it was done by a specially trained, they called her nurse practitioner or nurse there in the UK. So she had the procedure done, and the procedure took 8 minutes, according to this article. Is that how long a ERCP would usually take in ballpark?
I read the article and I did see where they mentioned it was 8 minutes. I don't know what to make of that because the procedure itself, probably the most challenging part of it is setting up the patient in the correct way. It's like a plane. If you take a short plane flight, even if you're just flying a 30-minute plane flight, there's a whole checklist that has to be done. There is getting the patient into the right position. There are a lot of things that have to happen for this to go the way you want it to go. And that takes a lot longer than 8 minutes. Now, the actual ERCP, that's pretty quick. Is it impossible? That's hard to say. I think if everything went perfectly, you're able to intubate, get into the right position, get a tome into the right spot, into the bile duct, make the cut, do the sweeps, because I'm assuming, as you said, they were concerned that there were stones stuck in this duct causing the pancreatitis. In excellent hands, I think it's possible. It does seem a little bit quick. I mean, I've never actually timed how much the actual procedure from like scope going in the mouth to a cut and then coming out. I'm pretty sure it's never been 8 minutes. I'm pretty sure it's always a little bit longer than that because we want to take our time with these things. Uh, but there's a lot about this case that is just I would love to know more about. I'd like to know a little more details about the patient, some things that might have made her higher risk, for example. but the 8 minutes was a bit of a red flag, I have to say.
There's a lot of unanswered questions, and in fact, we'll get into even more unanswered questions, which is that I guess right after the procedure, the patient reported having pain in her stomach. However, the article says that she was discharged an hour later. How common is that to discharge somebody an hour after an ERCP? Is that pretty standard?
That can vary from center to center. Most of the cases I do of an ERCP are not done on outpatients. Most of them are done in inpatients, people who are admitted with pancreatitis, for example, or cholangitis. If they have a stone that's causing a backup of the bile that gets infected, that can be deadly. So there is some emergency that's brought them into the hospital generally. Now, in those patients, almost very rarely, and if it goes perfectly, do they leave that same day. Generally, we keep them for a day just to make sure whatever brought them in improved, at least. And that's if things all go perfectly. We do sometimes do outpatient procedures. For example, if someone is an outpatient being worked up for a cholecystectomy to get their gallbladder removed, and as part of that workup, there's imaging that shows a stone, they'll come as an outpatient to recover from the anesthesia to make sure that they're okay, generally a little bit more than an hour. But centers can be different. And if there is a streamlined anesthesia process and they're recovering well and there's no issues, then yeah, they can go. Again, in this case, it's hard to know if the patient was having pain immediately after. That is that's kind of weird that they would then discharge them. Question was she having pain before? And is the same pain that she was having? Because she was having maybe gallstone pancreatitis. Was it gassy pain? Was it mild? How was it described? Those are things that are hard for me to know and give answers to. But certainly, you would be concerned if you did one of these really invasive, high risk procedures, like I mentioned, and then there is some issue going on afterwards. Generally, you do want to hold on to them and watch a little bit longer.
Well, what we know about this case was that she was discharged home, but then later that night, I guess her pain got worse because they had to call an ambulance, and she was taken back to the emergency room where they diagnosed her with a perforated bowel. Talk about that. Is that a known risk of an ERCP?
It is a known risk. It is thankfully low. In most places I've seen less than 1%, but it is a known risk. In any invasive endoscopic procedure, it'll be a risk. In this particular case, because we're making a cut there, that sphincterotomy, that does raise the risk above most endoscopic procedures. So it is a known risk. It is not something we commonly see, thankfully, but it is a very serious one. As you can imagine, if the gut contents, bowel contents are then released into the abdominal cavity, then that can be very dangerous. That can lead to sepsis, overwhelming sepsis, and that can has a very high mortality.
And that's unfortunately exactly what happened to this patient. She had the bowel perforation, she developed sepsis, and then within 3 weeks, she died. So, really tragic case. And I'm guessing, even though that's a known risk, you say it's a very low risk in the hands of an experienced endoscopist. Whereas I would imagine that someone without as much training might have a higher risk of such an outcome.
Yeah, what I will say in this process, again, there's a lot about this I don't know, but when I first heard about this case, I asked around with other ERCP doctors like myself to see if anyone had heard of a situation like this where someone who wasn't an MD was doing these procedures. And I was met universally with confusion about why I would even ask that question because we just never had imagined anything like that happening here in the States. And I really have a hard time imagining it ever happening here. And I want to make it really clear. I don't feel like just being a doctor makes you magical in some way. The fact that I was allowed to become a doctor and go to a good medical school and go to good training programs is proof that literally anyone can do it. Okay? It's not like, there you have to meet some basic criteria for intelligence and you have to have some learning aptitude and hands, skill with your hands and you need to be able to do all these basic things, but a lot of people can do what I do, what we do if you dedicate the time to do it. And that's the part of this that is hard to wrap my brain around is how much time did this person get in training to do this? Because again, I went through a lot of medical school, which was really important for residency, which was really important for the GI training I did, which is really important for the ERCPs that I do. And here, actually, even in the UK, there are, like, recommendations for ERCP doctors. They do recommend that they do at least 75 ERCPs a year to stay up to date. And in the US, they recommend that you get, like, 200 ERCPs during your training to before you go off into the world to do it. Now, how many training programs actually hit that mark? I don't know. But there's a goal of how many you're supposed to make, and it's emphasized that we have to do large numbers of these things, and you have to do them routinely. So, how much training this person got is really the question for me that troubles me.
Yeah, and who's allowing someone to do it with, assuming presumably far, far fewer procedures than certainly you or most people that are credentialed to do this. Now, you mentioned you haven't heard anyone doing ERCPs in the US that are non physicians. I haven't either. But what I have heard are non physicians doing serious brain interventions, all sorts of interventional radiology. They were training NPs to do colonoscopies. This is sort of a big experiment that we're doing across the country to figure out how we can overcome this quote physician shortage. And of course, in England, they have the National Health Service and they have a lot of challenges. And I'm assuming that's why they, in this case, allowed it to go this way. But let's
Yeah,
talk a little bit more about the aftermath and what was discovered about this case. So, one of the good things about the UK is that they actually do have these, what they call inquests. So, whenever there's an outcome, they do study it and they have a public release of information where they give you a report and they analyze it. It's not like the US where everything's kind of hush hush and secret because I guess of malpractice. So
yeah,
in this case, they had a review by the Royal College of Physicians and they reviewed actually all the cases that were performed by this single nurse that was being credentialed and allowed to perform these procedures. They found that between 2016 and 2021, this nurse had been allowed to perform 68 ERCPs. Of the 68, they found failings in care in 58 out of 68. And of those 58, those care deficits were so severe that 25 of those patients had harm caused to them, including this patient, unfortunately, who sadly died. And what they found was that this nurse was not giving proper informed consent. There were deficiencies in the ERCP reports, which I guess may be describing what was done,
hmm.
and poor radiological documentation. What are your thoughts when you hear that?
I mean, I'm wondering who's allowing this, who's willing to put their name on the line for this. I mean, I don't know how different the UK system is. I barely understand our own system. So I have to imagine that there's a MD that is willing to put their name behind this, and that's something I can't wrap my brain around. I mean, the number of cases that this person was doing was not particularly high. Is it high enough to maintain some proficiency? Yeah, maybe if the person had reached those numbers earlier, had gotten the training with the right amount of numbers, the numbers of complications there, depending on, again, it's hard to know because I don't know exactly what they're calling complications here or poor care, but it's certainly higher than we would expect. And again, it's a difficult procedure to do here, even in good hands. As I mentioned, we break into the bile duct system. We have to get our tome. We have to find a way to get into the bile ducts from the outside, go backwards. And that is generally one of the toughest parts of the procedure is being able to do that. It requires a lot of finesse, a lot of nuance, a lot of time, trial, error. And even in places that do high volumes of this, we need to have another ERCP doctor there to come help us. Sometimes that happens. You need to have somebody who you can turn to and be like, "What do you do in these cases?" And we aim for a goal of about 85% or more of those that we're able to get in and do and complete. So it means even in the best hands, these don't go perfectly all the time. So these numbers in particular that I'm hearing from this person sound low, and I almost feel bad for this nurse. Why was this person put in this situation where they clearly did not have the training to do what was being rest of them. And I would be fascinated to know what training the person got. I mean, is there any information about that?
Nothing in this report. I think you make a very valid point because if someone just tells you, "Oh, don't worry, you can do this. We'll train you." And you have, I guess, some hubris to think that, nothing can possibly go wrong until it does, then, it really is sad to be put in that situation. They have that old saying, you don't know what you don't know. If you
Yeah,
only see healthy babies being born, you think, oh, that looks easy until you have a baby that's born with a placenta previa or a shoulder
right.
dystocia or whatever it might be. Now, I do want to know what you think about this part of the report. It says the nurse consultant in question is subject to an investigation by the Nursing and Midwifery Council and has interim conditions in place on his, oh, it's a him. Well, that's interesting, on his ability to practice. So, what they're saying is that this nurse is actually being investigated by the Nursing Council. And that's one of the things we see a lot in the United States when there's an
Hmm.
issue with a nurse practitioner. They're not usually overseen or disciplined by any type of medical board. Do you think a typical nursing board is able to evaluate whether care being provided by a nurse doing ERCPs is adequate?
I have a hard time seeing it, um, because it's just not something that they're, I think, exposed to as much. I mean, in this country, our governing boards on this are run by medical doctors who are supposed to have good experience with these procedures and who have studied them, if not performed them daily themselves. So it's hard for me to imagine.
Is there anything that you wanted to say that we didn't get into about this case or ERCPs in general? And should nurses be trained to do this? What are your thoughts?
We're running into a, as you mentioned, a shortage of medical professionals, doctors. And even before this big, beautiful bill was passed that's going to really affect adversely medical school admissions, who gets into medical school and what kind of people we're taking, even before that, we were projected to have a deficit of doctors by the year 2036 by about 86,000. Now, granted, most of those are going to be primary care that we're missing. Those are going to be a lot of what's going to we need to fill the spots we need to fill. There's also going to be shortage of gastroenterologists and people who can do these procedures. That is a definite truth. So we do need to figure out ways to do this. We do need to figure out ways to train people appropriately for this. Do I see a situation in which those could be nurses or doctor extenders of some sort? I have a hard time seeing that. Is it impossible? No, I think it's certainly possible in very specific situations and settings where the training is adequate, where the training is appropriate, and we should not be dropping our criteria. We should not be lessening or loosening our responsibility. I think, if anything, we need to tighten those things. So it's a valid concern. Could it happen here? I like to say no, but a lot of things have happened here in the last 12 years or so that I never thought would happen here. So yeah, it's something that I'm definitely going to be watching very carefully of. And before you sent me this journal article from the BBC, that I never would have even considered it.
You made a good point earlier about who was allowing this and who was overseeing this. Somebody had to sign off. There had to have been, I would imagine, a physician who trained this nurse and who said that they're competent to do it. I think it's a warning for all of us as physicians to be very careful in who we're training and who we're authorizing to treat patients, whether it's primary care or whether it's a medical procedure. There is a lot that went into us becoming physicians, and there's a very slippery slope, and it can be very dangerous to allow shortcuts and to authorize that on our own. We're the ones saying it's okay. Meanwhile, we couldn't just do an apprenticeship to be approved to be physicians, right? We had to go through
Yeah.
standardized training. So it's a little bit of hubris on the part, let's say, of me if I was to say, well, I trained this NP or this PA, so they're good enough to go do anything. I
Yeah.
just don't think if it's not good enough for physician training, it's not good enough for any type of clinician training.
Yeah. That sounds very reasonable to me. Thank you so much for having me. If any of your listeners, viewers want to see more of this, hear more of this, They can check out my podcast, The House of Pod, available anywhere you find podcasts and that sort of thing.
Thanks so much for listening. I hope you enjoyed this episode. If you'd like to learn more, I encourage you to get the books Patients at Risk and Imposter Doctors. They're available at Amazon and at barnesandnoble.com. If you're a physician and you'd like to learn more about getting involved in our mission, which is advocating for physician-led care and truth and transparency among healthcare practitioners, then please join our group. It's called Physicians for Patient Protection. Our website is physiciansforpatientprotection.org. If you'd like to appear on our podcast, you'd like to share your story or discuss a case or an article, please send me a message through the website patientsAtRisk.com. Thanks so much, and we'll see you on the next episode.